Thank you for staying with the Monday Report. That conversation is still happening. Let's bring up some of the feedback and see what you're saying. A lot of it is coming through. I'll try and read through a few of them really quick. At Trevor Mbija at Citizen TV Kenya, use the hashtag Monday Report. We see GC says, never should we allow this to happen. Kenya Kwanza is slowly killing devolution, and it's evident from non-remittance of county disbursements for over 5 months now. Okay? Gulo says counties are unable to run health. Things have gone really bad since 2013. The experiment failed. Health should go back to the national government. Okay? Lynette Wasonga says no, taking it back is like insinuating that the county government has failed. This may lead to taking all the county's mandate to the national government, hence killing it totally. Pesa ziletwe mashinani, kazi iendelee. Mulunda Silingi says, let the national government devolve entire health functions together with its total resources. Governors will have no reason but to deliver. Peter Njiraini says, the government should not only take some services, but all the services, because the counties have shown that they can't be trusted with this service. Davji, what Senator Okechi is saying is that give the counties the money and let them handle healthcare services. You know, Trevor, I highlighted 3 issues here: infrastructure, personnel, medication, and medical equipment.
And one thing I want to answer first of all is this medical equipment.
Yeah.
You know, medical equipment was in this previous regime. It was a scandal. It's a criminal network. In fact, those people who are involved in this should actually belong to jail, because the reports on how all the procedures, all the laws of procurement are not followed. To the point that when you look into the counties, some counties like Meru, ICU that was meant to be in Meru is still Netherlands. In some counties like was in Gishu, they had a theater which was not operationalized for 2 years. If you look at Embu, a Shara facility, we had an orthopedic unit also, which up to the end of, I think, last year is when it started operating. In Umabe County, there was an MRI machine which was not utilized for all the period. So it was actually a scandal. It was a time bomb that I think if we are a serious government and a serious institution, we will have put people to books over this. And that's why any governor who supports the continuation of MES project then is part of this cabal or is part of this cartel. And therefore, MES was a wrong project. And ideally, it did not take into consideration the needs of the Kenyans and how services should be implemented.
Would it have been better if the counties managed the medical equipment scheme on their own, so that they pick what is needed rather than what the government did, where the resources were deducted from the source?
But the failure...
In fact, I wanted to improve his question. Just to improve it.
Yes.
If you are saying that the previous regime actually did do these bad things, and we know that in the previous regime, which accepted in the current regime,
yes,
the medical equipment services, both contractual and implementation, has been done by national departments and agencies. Why are you punishing counties?
So I'm actually
they were not responsible.
I'm seeing this thing to be both national and county government.
Yeah.
They're both involved into this, because you look at, for example, these counties that were having this particular equipment, they were actually they knew that they need healthcare workers to have them operationalized. They knew very well that the money that was meant for grant, 95 billion per year, was being deducted from national. So knowing that your money is being deducted, like for example in Kapenguria, West Pokot, where they paid 257 million for an ICU they never saw, and they don't act to this particular matter, it also shows that they were not effective. It also shows that they're not responsible. So it's a problem of both the national and the county government. And that's why we say we need an independent institution to make these things work. The other things on medicines or drugs, I can tell you, Trevor, you walk to any public facilities today, if you are lucky to see a doctor after staying for so many hours and go to the lab, and if you go to the pharmacy, you are most likely 90% are likely to be sent to go to the pharmacy outside. And there's a reality. There are no drugs in those particular facilities. And why? You realize that all the county governments hold KEMSA over 200 billion. It means even they also make it impossible to have the drug supply from KEMSA. And also you see these things that are happening in KEMSA, as we call it, the home of scandals, the home of corruptions. So you see, these things have not been working. So there actually has to be a deliberate effort for counties to be able to pay that KEMSA also to supply, which has been failing. When you look at the human resource aspect of it, that I has not spoken about, but that is the place where the rubber meets the road. I mean, it's bad. And I asked him, and this is the reality. We have governors in counties, 47 governors. We have their ministers, the MPs and the MCAs, why is it that they all have hefty private insurances and that none of them, based on the insurance that is paid by the taxpayer, goes to these public facilities that they own or that they run in the counties? Why is it left for the poor, that poor health care for the poor people? And that alone makes us understand why the government is paying 130 billion to private insurances, which will actually ensure that these funds go to private facilities. We as a union have taken more than 3 counties to court against removing funds from NHIF, workers from NHIF to private insurances. We did for Kiambu. That means we really want this public healthcare to function. Most Kenyans who visit these facilities, I tell you, see the reality. But most political leaders who actually just spectate and see will always speak differently on it.
So what about the infrastructure? Has there been an improvement in that?
What the governors have done and what has been done in all the counties is to see what will the residents have done. They build facilities. They build, quite a number of big hospitals have been built across the country, different parts. But Trevor, if you build a beautiful classroom, and then the children go to that classroom with no teacher and no instruments to teach them, will they learn? That's the same thing that happens to these hospitals. If you build a 7-star health facility in Nairobi or in Kiambu, and there is no human resource, there's no personnel to that particular health facility, nothing will happen. We have seen these cases in Mamalusi. We have seen it's a big hospital, it's a referral hospital, but you've seen the cases that comes up there because there's shortage of healthcare workers, which I believe need to change. We have seen Nyeri, level 5. Level 5 need to have consultants. They need to have neurosurgeons, but they didn't have. We've seen cases of master service being referred to KNH. We have seen mothers dying on their way to level 5 hospitals. And you will realize, even from that MES project, the only places where there was value was in KNH and MTRH, where there was personnel.
So this MES was a function done by the national government, and they failed at it. You're saying that it was corruption ridden. So why are you so confident now that if most of these functions are reverted back to the same people who failed, then this time they'll streamline it? Wouldn't that just open more loopholes for corruption, make the services even worse?
In fact, devolution of healthcare devolved corruptions down to the counties. That's why it doesn't work. So ideally, what we're talking about is not taking healthcare back to the Ministry of Health. We are saying create a centralized body that will manage the function of healthcare. The biggest problem here that actually occurs in the counties is the aspect of human resource. Because it is the human resource that if it's not there, there can't be healthcare. You cannot have healthcare without healthcare providers.
If it's a human resource that you're focusing on, then it means that all you want to take care of is ensure that your people are remunerated on time, because you also mentioned the TSC and police are on the national government. Is that the main concern here, not so much service delivery? Because
what I'm saying is because if a doctor is in the hospitals and it doesn't function, they will actually have a right to say, this doesn't function. You are not going to the hospital to supervise deaths. And we've gone on strike in 2017, and we're almost going this year, not because we demand more funds, but because we want the hospitals to work. It is whenever you go to the hospital and you lose a patient that you know you can actually help, you lose part of you. Doctors don't enjoy seeing patients dying.
So you want to reward indiscipline of the national government of not giving...
By giving them back...
The county governments, by giving them more functions so that they deal with it. It's like saying that this is your skunk, you deal with it.
No, not really. You see, you get the point here, is that counties have not managed to handle it in 10 years. And therefore we are saying, before this devolution of human resource of healthcare, we did not have any unemployed doctors in this country.
Okay.
The population of Kenya in 2010 was at 37 million or 38 million. But the main doctors are there were actually getting employed, the nurses and the likes, because there was a budget that was ensuring that you finish school, you go for internship, you go for this and this.
Okay.
Today, as we speak, the Ministry of Health is struggling to pay interns.
Okay.
Amount of 3 billion, all interns. Some from last year, August, some from January this year. Why is that happening? Because there's a misplaced priority, both in the national and the county governments. And therefore, we are saying, why can't we have an independent institution, a health service commission, or if it's a care track, can we have an enforceable framework with funding, such that this body then now discusses it earlier. This is the money meant for healthcare and for human resources.
So the push is not to take everything back to the national government, it's to have a health service commission.
A health service commission, or this care track to have teeth.
Okay.
An enforceable framework to ensure that service delivery.
Okay.
Because And that will actually help counties. Why am I saying this? Because the counties now will be able to actually purchase drugs from these funds that they're using to pay workers. Counties now say that their budget, the total county budget, 70% goes to healthcare.
Okay. Senator, do you have an objection with having a health service commission? Because I think Davji has now clarified that the issue here is not so much going everything back to national government, but have a centralized organization that can then handle their issues. Health Service Commission.
The Health Service Commission will be equal to legalizing corruption and telling people that if you're very corrupt, you can pay corruption, you can pay taxes on corruption, you steal a little bit, and then you are able to pay KRA, then we are fine with you. Why am I saying that? You are sanitizing bad political manners, both in State House and technically in counties, but counties not so much because they have not been given the money to be able to manage healthcare fully. You know, because even what they're proposing something called Health Risk Commission, which is basically how do we de-risk investment in healthcare in both national and local. If you are talking about de-risking national and grassroots Medicare, or some people call it Medicare, you have to be scientific about it. And you know, that this is what I think is lacking in this conversation, where professionals like KMPDU are having this conversation where they don't look at the underlying causes, among which the issue of disbursement of funds is the biggest, to be honest, the critical one. Because if you want to put an institutional framework that can be able to do de-risking element, then you have the best in the Senate. Because the function of Senate is audit function and oversight function, which are basically being able to ensure that the placement of capital in these different counties is well done. But what I was expecting from KMPDU as a framework for conversation, because now it's an advisory body that can be able to give both the county government and the national government a critical view of where we are going wrong. What I was expecting is looking at what has been given to counties and what has been given to national government, which what happens is the national government has been given what we call critical functions. And then the primary functions have been given to county government. Now, what I was expecting them to put in place is what I would call critical health indicators assessment, so that you assess impact based on that critical framework. And then you make proposals based on that. But if I do my own critical health indicators framework, I don't see where counties have gone wrong. Because all I need to do is take control experiment. Which county has got the best healthcare facilities in pre-devolution and post-devolution? And then which counties have got the least healthcare facilities before the advent of devolution, and then in the advent of devolution. And those are the two, Nairobi and Mandera. Now, we start with Mandera and then assess what has been going on in the last 10 years. At the time that we had devolution in Kenya in 2010, Mandera, if you start with something like maternity, Mandera had got 3,795 deaths per 100,000 maternity cases. Okay? That was the worst in the world based on the World Index on Maternal Health Care. Okay? After the advent of devolution, what do we get now? Mandera has got 388 deaths. That means that devolution has worked for Mandera. If you look at something like medical doctors, at the advent of devolution in 2010, Mandera had 2 medical doctors, Trevor. After the revolution, as we speak right now, Mandera has 114 doctors, 6 of which are specialists. If you look at something like general medical doctors staff, Mandera at the advent of devolution had 152 medical doctors. And that included both skilled and unskilled laborers in the medical field. What is happening today? Skilled medical doctors alone in Mandera are 1,400. Okay? If you come to things like facilities like oxygen, let me just finish. Let me finish. In Mandera County, at the advent of devolution, the oxygen plants that we had in Mandera was 0. Right now in Mandera, we have got 3 oxygen plants, and I think 2 are in Mandera town, and 1 is in Elwak. Lastly, We look at when we have got serious cases that needs intensive care unit in Mandera. At the advent of devolution, Mandera had 0. Today, Mandera has 6 beds for ICU and 4 HDU beds divided between Elwak and Mandera town. What does that show? It shows that the minimal devolved resources that Mandera is getting, sometimes even squeezing from their own budget from other areas, they have been able to reroute that money from devolution to be able to make it work for their medical services as a priority as they see as a county. But what is the problem is that even what they need to get, the national government, through the treasury, which is an appendage of national government and is not having an objective mind on how to improve these kind of areas, is not working. I haven't gone to the other control experiment when you come to Nairobi, which he was talking about. Just a second. Nairobi today has got 164 medical facilities. Only 5 of those are national referral hospitals. The rest are managed by Nairobi, including Mama Lucy, as he has said, and as he had correctly said. What is the problem there? Other national functions that have been left to national government, the people they are employing, are using these kind of facilities in Nairobi without paying for it. So how do you expect Sakaja and the county of Nairobi to be able to make Mama Lucy effective when they don't have functions, yet the people working for national government are going to these hospitals? I mean, the question that we must address is that can national government take counties seriously and just give them what is due to them under Article 2 or 3 of the Constitution?
Davji.
You know, in a normal curve, there are always those outliers in any normal curve. When you discuss the far-flung counties like Mandera, who have equalization funds, and who again, at the point of devolution, were within this advanced province of Rift Valley, then you have those particular statistics that is giving up. But one thing that you are going to realize that is the number of the health workers that are in Mandera go in line with the population. And realize that there's still shortage. So what are we talking about? We're saying that Mandera County, as it is, when we have the Mandera County referral hospitals under the national government, then it means that it will have the number of health workers that are needed, not just the small figures of 6 or 5. Because you see the cases that they have are still actually more. And if you look at the number of referrals that Mandera and other counties are sending to MTRH and to those counties are still very high. So that's the reality. So when you look at the overall aspect of healthcare in the whole country, both the public and the private, just the public, to have access to it, we must have the health personnel. And that's why we are giving the figures. But those figures have stagnated in Mandera for the last 4 years because they've been able to employ anymore.
All right. I have a question for you from Ted Munovi. Says, Trevor, 4 quick questions. Is the union leader just talking about remuneration to health workers? Is that all what healthcare funding is about? Number 2, teachers and other national workers belong to TAC or PAC. Has that necessarily led to a better pay and welfare for teachers and civil servants? Universal healthcare was piloted by national government in several counties, and it was a spectacular failure. While some counties like Makueni and Murang'a have implemented localized healthcare schemes with some assistance from NHIF, and it's working. What explains this? And finally, would healthcare workers be willing to get into contracts instead of permanent and pensionable terms to work for government facilities just like they do in private hospitals and facilities?
First of all, Trevor, the reality is that when the health workers talk, we don't talk about remuneration. We talk about the service. And it has always been said that when a crocodile comes from the water and tell you there's a problem there, the reality is a problem. And most of the people who are in the middle class who have some insurance, who can actually visit some of these private facilities, they don't understand until they get one disease that makes that insurance to be finished, and then they go back to reality of selling land and all other things. Because as I speak to you now, we have so many cases of people who are selling lands and are being detained in facilities, both the public and private facilities, because they can't access care. So that's one thing. When we are talking about these things, it's a reality for public health care. 83% of Kenyans will want to go to the public health care to access services. But because there are no services there, they end up in the private facilities. And you know the cost aspect of it. So that is the reality that we're putting up here. The aspect of the TSC and the Health Service Commission that we are talking about is just to ensure that we have a plan a plan to ensure that annually, the same way we have employed 35,000 teachers this year, and next year we're employing another 35,000, and the years to come, that happens to also healthcare workers. Kenya is the only country, Kenya is among the countries in the world that have reached the UN recommendation ratio for police. We have the ratio of 1 to 450. But then we have a ratio of 1 to 17,000 doctors, which means it will take us 50 years in case we're employing all the doctors that graduate every year to actually reach the WHO recommendations. We have some of the best policies as a country. And even as we speak today, most of our government guys, the health committee from the COG, the health committee in parliament, the Ministry of Health, are all in Geneva regarding these WHO policies and everything. But the implementation aspect of it is not there. And that's what we are saying. It will not be done by just a mere political rhetorics. UHC is a dream. It's a political dream that can only be realized when we link human resource aspect of healthcare from the counties to a centralized body with budget. Health has to be an investment.
Okay.
Yes.
All right. I would like to come for you closing remarks because we're running out of time here, but I see a lot of feedback on 22422. Let me see if I can read some of them here. The senator in the House is playing politics. He does not understand the day's topic. Counties have more corruption cartels. Health Service Commission is needed in Kenya. He says counties have more corruption cartels, and this is needed. Yes, health needs to be taken back to national government. Counties should deal with the preventive health care services, and national government to deal with curative and rehabilitative services. Okay? He says, Senator Eddie, how many doctors do we have in Migori? He says this is a person from Suna West. Okay? This is more saying the constitution is not perfect and it's not cast in stone. It is supposed to serve Wanjiku, and clauses that don't serve her by not providing good health care for the last 10 years should be repealed to remove healthcare from counties to the national government. That's Naomi from Nakuru County. He says 1 man, 1 shilling will allow heavily populated areas to improve upwards like Mandera by getting more funds to employ more healthcare workers. On medical matters, what about the cases of medics on study leave and on salary at the same time, making it hard for counties to employ new health workers because of no funds? Is this a reality? I've heard this from governors also, that some of your people, the doctors, go for studies and you have to pay them and they're not there.
You know, it's a career progression that is well anchored in the Public Service Commission guidelines. And it is not like they're going to study somewhere far. They actually offer services. Most of the doctors who leave the counties to go and study, they do at Kenyatta National Referral Hospitals, at Moi Teaching Referral Hospitals, at QTRH, and the likes. And what entails their study is actually treating patients in those hospitals as registrars. And they're the one who run these referral facilities. So that at that point, they're actually using the taxpayers' money for the value of the taxpayers' money. Okay. For the taxpayers, because they're not paid any other money on the side. Okay. Yes.
All right. You see, I wish health sector would be taken care of by the national government. Huku mashinani dawa zifiki. Most of the people here can't even afford medicine from private facilities. All right. Let's take some closing remarks here. Davji, so where do we go from here now? Closing remarks. So will you be pushing this agenda?
Number one, I think the MES project, the Managed Equipment Services, should not be renewed. And it is a corruption that if it is renewed, then that is exacerbation of corruption. Yeah. Number two, I want to bring it out clearly that in the counties that we're talking about, there's much more corruption. Today, as we speak, there are a lot of funds that when there's an advertisement, the board's asking all these doctors who apply, all these healthcare workers money to get these positions. And there's a problem that exists there. So in reality, and also the last that I want to say, and this is just to the ministry, the injustice that is being met at for the doctors, for the healthcare workers, for the interns who have not been paid the August salary for 2022, for the interns that have worked from January to now we are in May and we're still playing with their salaries, for the interns who graduated last year and some up to December and have not been posted. I think we're not going to laugh with the ministry over these matters because it's a right, it's well enshrined in the CBS and the Constitution that the service is for everybody. So there's no need for these people to graduate and left to wallow with frustrations at home. So we want the Ministry of Health, as they were doing, I saw yesterday in Geneva, to walk the talk. And walking the talk means you need to do what you got to do. You don't need to be forced to do your responsibility.
Okay.
Thank you.
Eddie? Closing remarks.
First of all, I want to make it clear to our viewers that today we were discussing the attempt by the national government, especially State House, to take the primary healthcare function from the counties back to the national government. And I want to tell Kenyans that this is a function that has been given by the Constitution to county government. You cannot take it constitutionally. You can only take it through a referendum process. And number two, the more critical issue of curative healthcare services is already with the national government. That is why, under Schedule 4 of the Constitution, national referral services are given to national government, and the dictates of policy making as regards to healthcare is also given to national government. Now, the question is the primary healthcare being managed effectively by counties? The answer to me is that it is yes. And I've given statistical analysis of why some counties have made some strides by rerouting resources here and there, but the eminent challenge that has been in terms of personnel resourcing, in terms of equipment resourcing, in terms of drugs resourcing, and more particularly in terms of facilities resourcing, has been the fact that the national government, especially the Treasury, has not been releasing money to counties.
Okay.
This is very critical, and the problem, therefore, that must be solved by us and Kenyans and also the professional bodies is how do we put pressure on the national government, the Treasury, to be able to release money to counties and then assess whether counties are paying your personnel or not. Right now, they aren't. CSVs, community healthcare workers, have done so much for counties in a curated kind of format in such a way that they can be able to identify preventable diseases, preventable conditions, and all these other things, but there has not been financing, money following those functions.
Yeah.
Lastly, I want to urge my brother Atella, because I'm talking to him as a professional. I came from the professional networks. I was in private sector. You know, I was a fintech specialist. And the one thing that professionals must appreciate is that anything that attempts to kill devolution is a dangerous thing for you, because devolution forms the substratum of being able to build the basic for humans at the local level, to be able not only to divide the cake that we have nationally, but to expand and create more cake by making sure that people have got the basics of life, that like healthcare, that makes them more productive in the society. So anybody who tries to talk about some ukora of taking devolution away, that person should be your enemy number one as a professional.
Okay.
Trevor, just to...
1 second.
Just to finalize, I want to tell my brother that he speaks like this and so well. And as we speak to you now, Migori County has only one gynecologist. It means that he needs to go down and get in touch with the healthcare of that county and see the dysfunctionality. I am sure when you come here next time, he will support the need to have this county. And
that is purely a resourcing function.
County referral, all these referral hospitals centralized.
That is purely a resourcing function. It's lack of money by national government not releasing funds. You cannot tell me
access the care.
You cannot tell me that the answer is giving back all that function to national government.
It's been there for 10 years.
It has never. For
10 years, you have not had a change.
It has never.
Senator, I am telling you.
The assessment framework, my brother Atella,
I'm telling you, Senator.
Before devolution, was Migori healthcare
it didn't have
facility and services better than it is now? The answer is no. Right now, we are in a better condition.
No, it is not. It is not, because I'm telling you, this analysis. But that was one county. But when you look at the reality, it's different.
But you're not accepting that before devolution,
it was worse.
We cannot put that into aspect because of the parameters has not been compared. And the situations were different. We also look at the population of pre-devolution. I told you we've had 20 million change in the population that time.
It doesn't matter, because
what the governors are specialized on, and I told my brother earlier,
brick and mortar,
is the PR.
No, it's not.
The governors will launch, will have a big lorry and then launch the drugs. Well, there's nobody in those facilities even to dispense it. Well, there is nobody even to write the prescriptions.
What is the reason?
Because they're not employed.
No,
so it is as, why will you buy the drugs?
This is what I want to tell my brother. The reason is basic that they don't have resourcing to do this. And I want my brother to go and do a scientific analysis.
Yeah.
Before devolution, was Migori County having specialists? Trevor, I personally had a problem that need radiology examination. I had to do it in Kisumu because Migori did not have one. We only had one radiologist in Kisumu serving the entire of Nyanza. Today, you can pride on Migori having one, Siaya County having one, because of meager resources that they get. But if there could be an improvement, it could be better. Specialists are more in Migori today and in Siaya today than pre-devolution. So the question is not whether they are not enough now. The question should be simple. You are doing an assessment on pre-devolution, and in the advent of scientific, now.
If it is scientific, we look at the budget of healthcare for the last 10 years and what you have done to the countries, including those counties. Because all these things have been funding. You see, you cannot say you compare 10 years from now and there's billions that have been budgeted for that period.
Gentlemen, we have to leave it
This guy was in the state house.
Sit down, just sit down.
I think it was well oiled. Like really? For ODM, who are given some small oil at Jubilee, and now you speak like government.
No, I'm just saying.
I'm sympathizing
I'm just saying
with
one
it because let me tell you the danger.
Health has failed in counties.
Now I'm advising you as somebody who is in government. Let me tell you the danger.
I'm not in government.
Let me tell you the danger. Let me tell you the danger because you're a professional body and I want to support professional bodies. I have got more respect. I worked with your brother, Oluga, right? And we had this kind of serious conversations. Let me tell you, you can go and form the Health Risk Commission. If there's no goodwill...
Health Service.
Yes. Health Service Commission.
Yeah.
No, you guys are proposing here a Health Risk Commission, but that's fine. Health Service Commission. But if there's no goodwill by State House to remove those funds from, or any supportive and facilitative functions from the ministry to support this Health Service Commission, take it from me, my brother, it will be another hogwash.
Okay. Gentlemen, we have to leave it there now.
So do a scientific assessment.
And the rate that you're putting up here is that it has failed 10 years.
Okay. We've really run out of time.
And solution cannot be defective.
Honorable Education Senator from Migori and Dr. Davji Atella, KMPD Secretary General on this issue of healthcare. We'll keep having this conversation, right? So this is it for now. My name is Trevor Mbidjon. On behalf of the entire team that made this possible, we say good night and God bless.